Hello, everyone. Thank you to the people that have joined us in the room, people that are connected online. It's a very rich and dense day, so thank you so much for being present with us today. So, one logistics note. So we'll have a presentation in English, the very first one. So if you need some translation, please grab a headset and connect to channel 1 for French. So, we have talked about a general conclusion, observation. We've talked about the difficult access to care and the universal access to care, especially for people in vulnerable situations. And in the European context, we're talking about undocumentation, for example. So it's an observation that we've focused on since the beginning of the scientific day. We've also tried on the public side of things to improve access to care to vulnerable people. So it's coming from the organizations, NGOs, it's coming from civil society-based organizations, scientists, but still, we are still facing today a huge gap when it comes to the access of care, and despite all efforts made. And despite technologies, we have more technologies available when it comes to treatment, diagnosis, and yet we still have a big gap in terms of access to care. And that leads us to the following question. What can we do better? What can we do in terms of interventions? How can we do things differently? And what are the alternatives to do things differently and better? Innovation as well is something that we're going to talk about for this panel. When thinking of innovation, we can think of 3 dimensions. First, creativity. We need to create something, we need to have a good idea. So how do you get a good idea in the first place? What is the know-how? What is the expertise that we're going to mobilize to create that good idea? Who has the right idea? How can we find it? How can we build it? We also have the notion of a rupture. It means that you need to forget about some habits, give up on some habits that have been, used for a very long time. So there are new ways of doing things, for example, for research, for mobilization. There are some resistance. So how can we manage that rupture? And third, there is also the durability. Valérie Ruide talked about this. And during the break, we're talking about, how fast innovations are. Having the right idea is great, implementing right ideas is great, running feasibility studies is great, but how can we make sure that the right idea, the good idea that we have is going to last, is not going to, fade away? So we have the question of transfer, modeling. We've talked about this in the morning. We've talked about scaling up ideas as well and the challenges we can face. So these are 3 dimensions of innovation. And to talk about this, we have a very good panel. I'm extremely interested in the project methodology, as far as I'm concerned. And we're going to start with a presentation from Bridget Draper and Annie Madden. Bridget Draper is a senior research officer at the Burnett Institute in Australia, and Annie is a project leader at Input. They are based in Australia, so it was complicated, to connect with them because it's 12 midnight. And so they've recorded their presentation, so we're going to listen to their recordings. And then we're going to listen to Mélanie Tarabbo, operational medical manager at Avila. She's going to talk about a very interesting system for biosecure emergency rooms for epidemics, Ebola more specifically, and how we can do better based on the knowledge and local know-how. And finally, we'll have Sofia Payotte, that's going to talk about a very interesting project, the STIMNUT project. with a community-based approach to psychosocial stimulation for severely malnourished children. So it's a participatory approach, local construction. So we're going to start with the project of Bridget and Annie. It's a multi-country project. It's called CUTS, for catalyzing uptakes of underutilized tools and treatment simplification for hepatitis C. It's based on tools and an algorithm to simplify the treatment and diagnosis of the disease and to test tools as well for prevention that were underused. They were not very used or barely used for several reasons. So if they were to be used more, what could happen? That's the question that we have. And we also need to rely on community-based solutions. So it's really integrated into the community. So we're going to start with this.
Draper from the Burnett Institute. And
I'm Annie Madden from Input, the international network of people who use drugs.
And today we're presenting on the CUTS Hep C project, designing and evaluating community-informed hepatitis C prevention and treatment interventions. So CUTS Hep C stands for Catalyze the Uptake of Underutilized Tools for the Prevention of Hepatitis C. And this is a piece of work that we're doing with the Medicine du Monde Consortium. So the Burnett Institute, just quickly by way of introduction, is an Australian-based medical research institute with an accredited, and it's also an accredited international non-government organisation. And here's our team. This project, the CUTS Hep C project, will take place in 3 countries, Armenia, Georgia, and Tanzania. And we started most of the work in January last year and will continue until March 2027, with implementation scheduled to start later this year. And it's in partnership with UNAID and the World Health Organization. So from this research, we're hoping to create sustainable change in health systems and the way services are provided. So to do this, our research must be centred on the needs of the community and be suitable to each country context. So across our studies, we're hoping to generate evidence on the feasibility, the cost, and the effectiveness, and the community's values and preferences to each of these interventions. And that will help guide how we design and deliver and evaluate each of the pieces of the study. So I'm going to take you through a hopefully brief overview of the 3 studies in this project. And Annie will talk a lot more about the community-led components and the values and preferences work that's embedded throughout. So hepatitis C, just briefly, it's a blood-borne virus that affects the liver. And now we fortunately have a really effective curative treatment for hepatitis C, which is an 8 to 12-week course with limited side effects, and it's very effective. There's around 58 million people who are living with hepatitis C globally, and there's still 1.75 million estimated new infections per year. People who inject drugs experience a high proportion of these new infections every year and are at risk of hepatitis C from different practices related to injecting drugs. This project has 3 studies. As I mentioned, the hepatitis C one focuses on simplifying models of care. There's one on low dead space needles and syringes distribution and looking at best practice approaches to introducing appropriate new options. And we're also exploring the feasibility, effectiveness, and acceptability of long-acting depot buprenorphine in Tanzania specifically. So firstly, on the models of care, as I said, there's a few barriers to accessing testing and treatment, and part of this is to do with the cost associated with tests and that people often have to pay to access testing and treatment. The multiple appointments needed to start onto treatment also can lead to a really big drop-off in people accessing testing that then don't go on to treatment. So we know that many people miss out on treatment even if they know they have hepatitis C because of the complex way that you have to get through this, we're trialling two different ways. So we're looking at a simplified treatment arm, which is following sort of global guidance at the moment, and then arm two, which is same-day treatment, where we're looking at reading the antibody test for hepatitis C earlier at 5 minutes, which predicts if people have current infection without doing the costly and complex RNA test, so that we can provide treatment to people with hepatitis C on the same day. And that's really our sort of intervention part of this study. So we'll be collecting data throughout the study to look at how people progress through from testing to treatment. We're going to ask them how acceptable these different models of care or pathways were. We'll talk to service providers about how they found delivering services in this way and what was required. And we'll record all the different implementation barriers and facilitators that we experienced throughout the implementation of these models of care. So we expect to be able to generate some evidence on the effectiveness, which is looking at the progression through the care cascade, the acceptability and feasibility of these two pathways to care. And we want to look at the accuracy of this 5-minute read time of the antibody test. So for the low dead space needles and syringes, we know that bloodborne viruses are often transmitted through sharing of needles and syringes. And so we're looking at the different options among needle syringe products to see if low dead space needles and syringes can help reduce the risk of transmission. And if so, and there's biological plausibility to support this, how do we best choose the right options and then provide them to people and sort of see if we can get more uptake of these low dead space options. So when we say low dead space options, we're talking about the little bit at the end which can retain blood, and you can see in the image that there's higher dead space options where more blood is potentially retained, and then there's the low dead space where there's less retained. We hope to generate evidence on these best practice approaches for choosing, implementing and providing low dead space syringes in a distribution program to then achieve high uptake of these new options. And we'll do this in a phased approach. And Annie will talk a lot about phase 1 and about some of phase 2, and I'll talk quickly about phase 3 and 4 now. So we can see that throughout phase 1 and 2, we're really focusing on selecting the right products, and that informs phase 3, which is our distribution program and evaluation of that distribution program. And we'll do the evaluation in a few ways, collecting routine programmatic data on the types and number of needles and syringes distributed to each person, and then also through a dedicated cohort study where we follow the same people over time and try and understand if people choose to use the low dead space needles and syringes. And we'll also record and link any hepatitis C and HIV test results to see if we can see any association with new infections in these different groups. So we expect that we can generate some new knowledge on how to design and implement these programs and how effective they can be. And we want to be able to show people how this can be done and hopefully provide some evidence to update guidelines and inform the delivery of needle syringe programs globally. And to finish, we have our final study, which is just in Tanzania on long-acting formulation of buprenorphine, which is opioid agonist maintenance treatment option. And it's a potentially beneficial additional option because it can reduce the amount of times people have to come to a service, so they can come monthly instead of daily or weekly. It can have positive effects on quality of life and treatment retention and satisfaction, and it's another option to explore in what we can provide people. So the feasibility is really just to understand what it takes to introduce long-acting buprenorphine in a new setting. So we're thinking about the staff, the training required, the infrastructure, and what sort of happens during the implementation and what it costs. Module 2 is about effectiveness. So we're doing a prospective non-randomized trial where we observe people who choose to try out long-acting depo-buprenorphine and those who choose not to. And we're measuring patient-centered outcomes, so treatment satisfaction, retention in care, and also non-medical opioid use over time. And in addition, we know that transitioning from methadone to long-acting depo-buprenorphine can be quite tricky. So we want to observe and measure this sort of transition induction period to understand how that goes for people and whether people continue all the way and start on LADB and what's the experience during that period as well. So from this study, similarly, we expect to generate more evidence on the feasibility, acceptability and effectiveness of this intervention. And we hope to contribute to widening the choice for people seeking opioid treatment.
Hello, everyone. As we said in the beginning, my name is Madden, and I'm the project lead for the Cuts Hep C project for Input, which is the international network of people who use drugs. Input is the global network for people who use drugs. Our members are the regional and country-based networks of people who use drugs around the world. I'm also a principal investigator for the Cuts Hep C project and leading on the community-led qualitative values and preferences research. And just going to the issue of community-led and our commitment to that. So I also identify as a person from the community, and I have my own lived experience of the issues that we are researching, including opioid dependence treatment and injecting drug use. So today I'm going to talk to you a little bit about the community-led qualitative values and preferences research, and mostly I want to focus on the methodology or how we're going to do that research. But before I do that, I just want to touch a little bit on why community-led values and preferences research is so important in the kind of research that we're doing. So interestingly, one of the things that has come up a number of times since we've been designing this research and has been asked of me is kind of why do we need to do values and preferences research that's really embedded across all of the work we're doing when we already know what people who inject drugs think about low dead space syringes and needles, for example, from other research that has been done. And what I typically have said to that question is, you know, as we know, every context is really different, and even sort of small or seemingly small issues can be really important, particularly when it comes to something like harm reduction and injecting drug use. So, you know, each from context to context, the drugs used can be different, the language spoken can be different, the way people communicate about their drug use can be different. There can be different socioeconomic, geographic differences, and also differences in how services are delivered, just to name a few things. I mean, it is fair to say that low dead space syringes and needles have been available for some time now. Indeed, we've even had a recommendation on their use in harm reduction settings from WHO since about 2012. But despite this, low dead space syringes and needles are still not well used outside of high income countries, which is where most of the research has been done. We think one of the major factors behind this is due to a lack of proper consultation with people who inject drugs, particularly in low and middle income countries. And even in the few occasions where there has been consultation with people in those settings, often we find that what is recommended by the community hasn't actually been implemented in practice. And this has resulted in people who inject drugs being asked to use low dead space syringes and needle products that are really not fit for purpose. And then, not surprisingly, beneficiaries or people who inject drugs reject those options, and they say they don't like using low dead space syringes and needles. And as Bridget has already rightly explained, this is a real issue because these products can in fact have really beneficial impacts, and so not having access to them can have serious consequences for people. In relation to long-acting depo-buprenorphine or LADB, which, as Bridget has said, is one of the other harm reduction components that we are looking at, it is a different situation, but surprisingly sort of similar in many ways. There has been little or no consultation with opioid-dependent people in low and middle income settings, particularly on their needs and preferences. And again, getting this wrong, that is not properly understanding people's needs and preferences, can have really serious consequences for people because of the benefits that can flow from these types of therapies. So with all of that said about background to why community values and preferences are important, I just want to say a few words about, why we thought it was important to do this work. So like other research, community-led values and preferences can help us understand the issues and people and context much better than we might otherwise. But unlike most research, community-led values and preferences research is also fundamentally about community empowerment and galvanising community ownership. That is, communities really being heard and their preferences and needs being taken seriously and acted upon. It's also not just about communities leading on the questions that might be asked, although that is obviously part of it, but it's also about communities leading on finding the potential solutions to what are often complex questions. It's about communities having the chance to speak about what matters to them, what they value and why they value it, how their preferences are shaped, and what factors might act, for example, as barriers or enablers. It's also about, and as Bridget has touched on this as well, it's about communities being embedded or involved in all stages of the research, right through from concept, right through to dissemination and all of the stages in between, which is what we are endeavouring to do here. For me, I think community-led values and preferences research are a chance to start thinking about people who inject drugs not just as beneficiaries of services, but really as experts in our own lives. And like other experts, we want to be leaders in the knowledge generation on the issues that directly affect our lives. So with that said about the background around why community-led values and preferences is important, I'm now just going to focus on some of the methodology in the research that we're planning to do. So as you can see here on this sort of diagram of the overall study design, this sort of blue column that sits right through the study, across the whole study, is the values and preferences research. And I think it's just a really good visual on how embedded the values and preferences research is in the study, but it also highlights for you that this research in terms of methodology will basically occur across 3 phases of focus groups. So in terms of the phase 1, this is the pre-implementation phase, and the first focus group will be with participants will be people who inject drugs, and they'll be identified and recruited through largely local networks, word of mouth, through harm reduction services on the ground, peer educators, etc. We'll have about 25 participants per site, but some countries have multiple sites. We'll be looking, though, at having really quite small focus groups of like 5 to 10 participants each, because we really want to encourage a lot of in-depth discussion on the issues. And this, I guess, is most importantly here is these focus groups will be facilitated by a trained and supported community researcher and note taker. And that is someone from the community who will be facilitating the focus groups and taking the notes. And input is in the process at the moment of developing extensive training for the community researchers and note takers to support them in this work. So during focus group 1, participants will be given multiple brands and samples of low dead space syringes and needles to be shown and demonstrated how they work. There'll be different sizes and volumes and gauges and different types of products. And we'll also make available the current equipment that people get through their needle and syringe programs alongside, as well as high dead space product options, so that people can very clearly see the differences between low dead space and high dead space products. And we will have discussion to assess initial values and preferences, and also talk about people's education needs, what sort of information, education and knowledge mobilisation activities might be needed in the phases 2 and 3 to follow. So the phase 2 pilot stage, participants who elect in focus group 1 to participate in the pilot will be able to access the low dead space syringes and needles through their usual NSP program, and that will happen for about a period of 6 to 8 weeks. Toward the end of that pilot period, we'll bring people back and ask them to participate in another focus group, the second focus group, which will operate on much the same sort of size as the first one, and again will be facilitated by a community researcher and note taker. During the second focus group, we will be focusing on asking participants about their experience of using the piloted products, reporting their overall impressions on those products, if they would use them in preference to other injecting equipment or not, and also assessing how they found the education and information that was provided around low dead space syringes during the pilot. And whether we need to do any further work on that information and education for the phase 3. The aim of focus group 2 really is to gather community preferences regarding the piloted products and to really confirm what products will go through to the wider distribution phase in phase 3. During this final focus group, we'll be talking to participants about their experiences of using the low dead space products over a period of time. Again, their overall impressions, but also drilling into how often they use the products, whether they use them sometimes, all the time, whether they continue to use them. And really what we're wanting to get at here is the idea of uptake versus usage. So people might take the low dead space products, but do they use them? And if they use them, how often do they use them? Then very quickly on the LADB study, again, the broader goal of that, as Bridget has outlined, is to generate evidence on the feasibility, acceptability, effectiveness and cost effectiveness of introducing LADB, and also, again, to influence or inform global and local policies and guidance. Again, the values and preferences work will be focused on this acceptability component. Very briefly on this, the LADB values and preferences, its key objectives will be to assess the values and preferences of people with opioid dependence in relation to LADB, and really looking at things like benefits and disadvantages, facilitators and barriers to LADB being offered and made available, looking at preferred models of care and service delivery, and also in relation to values and preferences, looking at some of the structural and other barriers that people may experience, particularly for a community that is highly marginalised and criminalised. It's really important to understand how some of the structural barriers and other issues can affect or influence how people, whether they're interested in something like LADB, how they engage with treatment or not, and also, importantly, their perceptions of efficacy and safety. The methodology for the LADB values and preferences work has really got 2 key data collection points. There'll be focus groups at the enabling phase, which will be prior to people going on to LADB. We'll then come back toward the end of the implementation phase, which will be approximately 2 years. And then we will do, instead of focus groups, we'll do key informant interviews where we'll talk to individuals in 3 arms, basically. There'll be an arm of people who have been maintained on LADB, another that perhaps started LADB but chose to discontinue, and then another arm of people who were offered LADB but opted to stay on methadone. And in the first arm around maintenance, we'll really be looking to understand people's experience of LADB treatment, the pros and cons associated with that, their impact on their quality of life, things like housing, employment, family, those types of issues, and any recommendations they might have for how services might be improved and delivered in an ongoing way. In arm 2, this is the people who went on LADB but discontinued. We'll really try to explore their reasons for discontinuation and again ask them about any recommendations they might have around service quality improvement. But importantly for this group as well, we'll also be interested in whether they have any support needs. And by just acknowledging the consortium that Input has the great pleasure of being part of here. It's really been a genuine privilege to work with Medicines du Monde, Burnett, and Bristol University from inputs perspective. It's just really amazing to work with a group of organisations and individuals, frankly, that are really committed to improving the health rights and dignity of people who inject drugs and people who use drugs. And so I just really wanted to acknowledge how, it's been a real privilege to be part of this consortium, and we're really looking forward to continuing on the work.
On remercie.
Thank you so much for sharing this research with us. Extremely interesting, and it really underlines the importance. I think also at the title of our scientific day, the importance of understanding before transforming. You can't act and try and transform things if you haven't understood the local context. And I think it leads us to how important it is to have some local expertise and having communities to participate as well. We've seen that in the previous roundtable. It's really important to work hand in hand with the community to benefit from the local expertise. And I think this is a perfect transition for the next intervention. Thank you so much for this opportunity to present the Cube, which is the biosecured room. So this is something that was developed by ALIMA. ALIMA is the Alliance for International Medical Action. So the model is quite specific. The first one is the alliance in between people in the field and the NGOs. We also have the Ministry of Health, and we have, of course, national and international research institute, where you have to, you can note also that the NGOs and our partners, they're also part of the board of ALIMA, actually. So our operational headquarter is based in Dakar, and 98% of our employees are actually from the countries where we are present, where we intervene, and 85% of our senior executives are Africans. So Africans because ALIMA is mainly in Africa at the moment, but this isn't the only place where we do work, because we always want to work local population, and we want to make sure that local population is at every single level of our organization. And the third pillar is really linked to what we're talking about today. This is a research and innovation. This is at the heart of the ALIMA model, which is a unique model. We always want to reflect. We want to be thinking about what we can do with our beneficiaries, with our organizations, with our partners that usually have a better expertise. They have a better knowledge of what's happening in the field, and the idea is to develop research projects and innovation projects. Currently, over 20% of our activities of our research project are research projects. I just wanted to give you a light overview of where we work. As I said, our NGO is only 15 years old, so we're quite young actually in the humanitarian sector, but we've already developed a certain number of projects. We started first in Western Africa, now we also work in Central Africa, and we have been developing for the past couple of years Eastern Africa. We also work in Ukraine actually, and we are reopening Haiti. We used to be there a few years ago, right after the earthquake, and after, of course, the epidemics that the country had to go through. We also work on with mothers and children. We offer responses to breakouts, to epidemics, and we also work in research. So to get to this innovation, maybe I can give you a bit more context. So why did we have to innovate? So let's go back to 2014. We have this unprecedented epidemic, and I'm talking of the Ebola virus, the Ebola disease in Western Africa. I think everybody remembers that epidemic. We had over 11,000 people that died, including a lot of health providers. And the intervention methods were not really adapted to the magnitude of this epidemic. And the problem is that a lot of the local population had no trust in NGOs. And so we had treatment center, Ebola treatment center, we call them CTE. So those are massive structures, which are basically hospitals that we were building on site. It was taking us 35 days to set them up, which is huge when you we are in the middle of an epidemic. Here again, the cost is quite significant, $1 million US to build up those temporary hospitals. And we had to gather people that were sick. And so to give you an example, in Guinea, for example, we had one unit for 3 different districts. So of course, we can wonder what it means for access to care and for populations that lived in remote areas. So we had 20 beds for which we had 250 staff members so that we could isolate the patients. And I'm not saying cure or heal or care for patients. I'm saying isolate the patients. And so I think you all have in mind that the pictures of health providers that were in their whole outfit. We've had those images not so long ago with COVID as well. But imagine when you are in a country in which it's extremely hot, there is a very high humidity rate. You can probably just stay 45 minutes next to the patient because the heat within your outfit is just your sort of jumpsuit is just so hot. And so, of course, you can imagine that this is very tough conditions to work in. And this is also a lot of stress for the patient, of course. And it makes it just harder for the medical staff to actually care for their patients and try and treat them. We were more isolating than treating them. So here you can see you have the undressing part, the decontamination part. There was a lot of issues regarding waste management. It's a lot of work. It's very complex to organize. For the treatment centers, here you can see this massive ward. Here you have just patients laying down on beds. We can also imagine that these people can have. We have suspected patients, of course. So we were trying to separate them from sick people. But it's really hard to administer any type of treatment here. So here, for example, you have a patient on the medical staff on the inside and a medical staff on the outside. The idea was just for them, to be able to communicate, to be in contact, and for people to be in contact with their family, that were patients. It was impossible. So here, the treatment center were not so close to the focal points of the outbreaks, and usually people were taken care of really far away from their household, from home, and sometimes we're just. I'm not going to say kidnap, but I'm still going to use the word kidnap here. But we're just kidnapping that person, taking that person to the treatment center, and they had one chance out of 2 to actually to make it alive on the other side, and they had no contact with their family. So we can understand that a lot of people were quite reluctant to actually go to this treatment center, and this is also what participated in that outbreak. So there are many different challenges that we were faced with. I'm not going to mention all of them, but maybe I can insist on 3 different points here. So we have access to care. So it was just, as I said, difficulty to care for patients. We were not really able to care for patients. We were trying to treat their symptoms. That was the first point. The second point is that a lot of people were really reluctant to actually come to the treatment center. A lot of patients didn't just want to get here because they wanted to stay in contact with their family. And the last point, I think, is that this type of intervention was set up really far away from the focal points of the outbreak and really far away from the community that was impacted by the outbreak. So that was the issue here. And this is why Alima wondered how they could innovate and try to change the model right after this epidemic, this huge outbreak that we had in 2014, 2015. And so we thought about how we could change things. And so the main idea was to isolate the patient. And I'm not talking about isolating them as in marginalizing them. I'm talking in terms of biosecurity here. And you'll see we actually made sure that the patient was going to be in contact with their family again. The objective here was to have a very light system that would be adaptable and that we could actually set up as close as possible to the outbreak focal point. And so for this project, I think we could divide the project in 3 phases. So first, we had the design phase, the research phase. So we had to document the issues that we were faced with. So we had to analyze all of the interventions that we contributed to. So we were able to talk with patients, to talk with health providers, to field teams, not just Alima, not just Anima co-workers, but people that were also working in the field. I'm thinking of the Red Cross, with Doctors Without Borders. With Anima, we were in Guinea, so of course we also talked with Guinean authorities. And so here we were just discussing with partners and impacted population, because we really wanted to understand what was important to them. We also, of course, went to other countries to see what was happening, namely in Europe. We went to France with the T4 lab that are quite used to treat this sort of a virus. We visited Bordeaux, London. We were trying to see how they were actually trying and treat patients that were sent back to England or to France. They had to treat these patients that had the virus. So we're a medical organization. We're not a company. So of course we had to find a partner that could support us in creating this new system, which is the Cube that we call it. So this is a biosecure emergency room for epidemics, for outbreaks. Then we moved on to the second phase, which is all about the development and the implementation. So here we have a cross-disciplinary project. It's really important because we wanted for the Cube to meet the needs of the patient, but also to meet the needs of the health providers and of the staff member. We had to work through decontamination and everything. And so here we created a prototype that we've tested and we kept on improving before moving on to the third phase, which is the phase of adoption and deployment. So this is something that we've done in the field when we had outbreaks. So we tested in real conditions. We've been able to see whether it was a tool that was acceptable, and if it was, changing things, and if it was just doable. Could we actually implement this type of biosecure emergency rooms when faced with outbreak. And so this is a tool actually that we keep on improving. We keep on improving it at every single intervention. We've also installed a process that really helps us to get some feedback from the patient, from the community, but also from the health providers, so that we can keep on working on improving that Cube. So the technical specificity, specifications, I'm not going to go too much into details. I think the little drawing that you have at the bottom right, shows you how it looks. This is an individual room with a transparent material. The material is extremely resistant, so that we can guarantee the biosecurity. You have negative pressure inside, filtration, water tightness. We have a stainless steel structure that we can deploy and dismount quite easily. And you also have this intra-wall passage device set. So here basically you can put your arms through this wall, so you can treat a patient with having to get in the biosecure room. This is really easy to transport. It's a kit that is made out of three boxes. You can put it on a pickup. You can put it on a motorcycle, on a helicopter. It's really easy to deploy. You can build a biosecure room within 90 minutes if you're 4 people, but actually if you have more experience in deploying this type of room, you can go even faster. Also, the cost is quite low, and so here, when we're talking about a reduced intervention cost of 75%, it's only for real treatment here, because we also do resuscitation and intensive care. So it's hard, to compare the cost of it, but it definitely is much less expensive than those massive treatment centers that we were deploying at the time. Here you can see Dr. Richard, who's the president of Anima. He's also a resuscitator, so he's working on from the outside, and this is something that we couldn't do at the time. So as I said, we were working on prototypes, and once we've had the prototypes, we've been able to deploy this on three different fields, and then we've been able to work on improving the first Cube. So the first one that we've deployed was in Owo in 2019. So Owo is in Nigeria. We had the Lassa fever and the other diseases. Of course, it wasn't just for Ebola. And so here we've had a criteria of the disease that was quite complicated, with a high mortality rate and a lot of different symptoms. Then the other real condition test was in Itipo in DRC. So we've deployed 7 of those cubes at ITPO in May 2018, and in August 2018 still we've installed 9 cubes on a longer site. So the test was validated because it's really quick to deploy. And as I said, in ITPO, for example, in less than 7 days, so within 7 days, we've been able to identify, so 7 days, happen between the moment in which we've identified the site where to deploy the cubes and the moment we treated the first patient. So now we still have the possibility to care for patients, to treat patients thanks to the suit. We can monitor continuously the patient, which is a revolution when it comes to outbreaks here, because we have Bluetooth medical devices, or we can get also wired devices, and the wires go through the wall. So we've been able really to improve the type of care that we can offer to patients. So it's not about only being isolated isolated and just treating symptoms. We can go through intensive care. We can do resuscitation care as well. And we've also been able to do some clinical trials so that we could identify medication, identify drugs that were very efficient against Ebola. The main change, the main revolution, which is probably the biggest and the most important change, is the proximity with the family. So these structures are much more accepted by the community, because people are being treated closer to the outbreak focal point, so closer to their family. And the centers can actually be open to the families. The families can get in the center, or community leaders also can come in, but they can just come in there and see the member of the family that is a patient that is being treated in the center here. So I just want to give you an overview. So here we can create small structures with just a few cubes in really remote areas. We can also create a big treatment center. Here, this is one in Mélanie. You can see that cubes were for people that had to go through intensive care. We've put them some sort of in a semicircle position so that we can keep an eye on all patients at all time. And we had bigger structures for suspected patients. Of course, we were faced with quite a lot of challenges. We can't provide every type of care in those cubes. We still have to dress up. We still have to decontaminate once we're done with the patients. So we still have medical staff that has to get in those biosecure room. It wasn't easy as well to change people's habits, because they were used to wearing their PPE. They felt safe enough with their PPE, and changing their habits and try and teach them that they could now treat the patient from the outside was quite of a challenge, because they had to change their habits. It's also a biomedical system, which means that it's important to maintain the system, to maintain that biosecure room properly, which was also a challenge overall. And so to conclude, this is a very innovative tool that really contributed to reducing the mortality rate. I mean, it wasn't the only thing. We had treatment, vaccines, of course. There is Doctors Without Borders that has developed a new suit that can be used. I mean, many innovations were brought to life, and I think we really changed the way that the medical staff actually interacts and works with patients, which I think is a great point. We've been able also to get the patient closer to their family, which really contributed to changing our intervention strategy at the international level, actually. We started really changing the strategy, deploying much closer to the outbreak focal point, and reaching people that usually are really far away from the medical care. So here I just wanted to give you some bibliography, so you can some references. There was one publication that was done regarding the results of the clinical trials that we've conducted, so in everything that Alima participated into. And thank you for your attention. Thank you so much, Mélanie.
Merci beaucoup, Mélanie.
And this is a very interesting system that you take into consideration the local expertise and how people work in the field. You also talked about, what brought you to innovating, which is also quite interesting. You've been working with local partners, and I think that's a great transition for Sofia, who's going to tell us more about the STEAMNUT project. Hi, everyone. And thank you so much for inviting me. I'm delighted to be here to tell you more about STEAMNUT. STEAMNUT means psychosocial stimulation for nutrition. So this is a research action project that took place in Mali, so in a rural area. And the idea was to improve the treatment of children that are severely or acutely malnourished. So I wanted to give you some context element, to tell you a bit more about how this project was created. So the ministry, the Mali Ministry of Health has done a report on children that suffer from severe malnutrition. You can have deficiencies in terms of emotional development. You can have mental disorders and development disorders overall. So these children are just lethargic, which doesn't make it easier for us to interact with these children. So faced with this problem, the Ministry of Health from Mali decided to go with psychosocial stimulation for rehabilitation, but also afterwards, once the child has been treated. And so here we have a second observation. It was really hard for health structures, but also for health professionals to actually implement this recommendation of psychocognitive stimulation. There were many different questions on how could we actually do this, how could we implement that. And this is when the STEAMNUT project was born. So this is a research that was done by Epicentre in cooperation with Doctors Without Borders, but also with the Ministry of Health of Mali, with Action Against Hunger, and AMED. So the first question that we tried to answer to was, how can we integrate the psychosocial stimulation in nutrition programs? And so you'll see, we did not invent anything, quite the opposite, actually. We started from what was already there, from what we already had. So we referred back to a manual that was elaborated by Action Against Hunger. It is called FUSAM. FUSAM is a project that explains how you can implement 5 sessions of psychosocial stimulation. So you can work on 5 different psychosocial factors. And you can see here on the side, every single session has a different objective and a different theme. And the beneficiaries, of course, are children, but also children carers. And so I'm going to talk about carer on the feminine, female carer, actually, because here I'm talking a lot about mothers and grandmothers, and mainly women are actually taking this responsibility. And so the idea was to adapt this FUSAM manual, this FUSAM guide, to the context of Mali. So this is the end of the day, so I'm not going to spend too much time when it comes to the methodology, even though I'd be delighted to tell you more about our methodology if you have questions right after. But before implementing the adapted manual, what we've done is that we've collected a lot of data, and then we've done a lot of interviews and surveys and so on. And we've also called upon different players, and we called upon them for them to become members of a committee. So these players, it was that could be representative of local authorities, that could be therapists, that could be parents, inhabitants, health agents, and so on. So they all gathered. We've had 7 collaborative workshops that were that were organized. So we all gathered together so that we could think about how we could improve the treatment of children that suffer from severe malnutrition. So here you have a few pictures of the workshops. On the other side, you can see one of the family benefiting from the STEAMNet program. And I just wanted to tell you a bit more about how these different players mobilized so that we could improve the treatment path chosen. So first of all, we had to identify the challenges. So this is something that we've been able to have feedback on during the workshops. So, you know, it's a lot of limits, a lot of issues that make it harder for children and female carer to actually have access to care. So from the moment that the carer identifies the symptoms in the children, the first thing that they will do is that they will self-medicate. So that will be through plants or drugs that you can get directly at the market. If the symptoms persist, what happens is that carers usually go to healers or traditional therapists. And we observe that in those first two phases, carers are usually quite autonomous. However, when they have to go to a health center, here you will need to negotiate with the husband or the leader. And so here there is a second negotiation actually that comes into play once the diagnosis has been given and when it's all about finding the treatment and getting the treatment. So here, you know, this is challenges that we're faced with within families. We know that women and mothers are usually overworked, they're overwhelmed. And when it comes to health centers, and I think it's important to remind you of this when we talked about stigma, for example, but mothers that have children that are severely malnourished, they're stigmatized. Including in health centers, actually. And this is the case in Mali, and this is the case in other contexts as well. But we are also able to observe other challenges, other barriers. For example, we don't have the right equipment to do some psychosocial stimulation, for example. So those were the challenges that we're faced with. And now I'd like to show you on this treatment pathway where the workshop members actually made recommendations or given leads to implement new actions. So there is a recommendations when it comes to the treatment, because of course we adapted the Fusa manual, as I said. So they suggested, for example, to take into consideration the family's totems. What's interesting here is that they actually dug deeper, and they've also proposed recommendations to try and implicate a bit more to involve men more. So, for example, during some kick-off ceremonies, they've also underlined the fact it was important to focus on the wellness of women. And it was also quite interesting to see that the participants to these workshops, they suggested recommendations to improve the treatment of these children, but also to support another vulnerable population, that is to say the female carers, because the mental health, their mental health can be really fragile because of what they're going through. And so sometimes they don't have enough autonomy, and they also do not have decisional power when it comes to treating their children. So here I wanted to show you some results that talk about the transformation that occurred. So we talked about the change of perception, of behaviors, as well as interpersonal relationship. So we've observed that whether it was in a health center or whether it was within families. For example, we were able to observe that the implementation of STEAMNet gave more value to roles and activities that were already there, that already existed. For example, health agents that had a very important role when it comes to raising awareness, for example. we're given more recognition. We can also see that there is a better relationship in between the health provider and the patient. There is more trust. There is also a disconstruction of bias when it comes to mothers. And so a lot of behavioral change within the family as well, because we've been able to observe that the relationship in between mothers and relatives were improving. So, for example, the members of the family actually changed the way they look at the female carer. Now we see in them a certain expertise because they talk about stimulants as a training, actually. And on the other side, when it comes to the perception that female carers have of their own person, they feel more legitimate and they feel more efficient. We could also observe improvement in the relationship in between mothers and children. Mothers are able to express more positive emotions. And finally, we've also been able to see that the links, the relationship in between the child and the relatives was only growing and getting stronger. And so here I'm not going to comment everything, but maybe just the quote at the bottom here. This is a mother explaining that there was absolutely no relationship whatsoever in between her baby and the father of the baby, and that after Stimnet, she says he's playing with the child. This morning when we called, he was actually playing with the child. So to go back to the initial question, so how did we get different players to get involved? And I think if we had to sum up our method, is whether when we organize the workshops or whether we talk about the training with the social workers, because those trainings were extremely were interactive. So we always had those 3 steps that you have here on the screen. Is that first of all, we were able to recognize the role, but also the expertise of every single player. We were listening to every single of these players. Then we were identifying collectively, and I really want to insist on collectively. So we were all trying together to identify the different issues. We were trying to identify the challenges and the objectives. And then finally, we were facilitating collective research to find leads of improvements. And finally, I'd like to conclude on some food for thought. What does that mean to design and to implement innovation with and for the community? Usually we talk about the community as a really homogeneous whole. But I do think that it's really important to remind you that within one community, we usually have different identities, different social groups as well. They have different roles and different statuses. They're interacting with one another, but they interact according to social norms that are really specific to each culture. And we already have people that are dominating and people that are more submissive. And so as researchers, I think it was really important to think about this. And as humanitarian agents as well, how can we face those social inequalities that are already there? And it also brings us back to having to make a choice. Do we adopt a universalist approach or a cultural relativism approach? So for our case, because we're talking about improving the treatment of children, it was raising a lot of inequalities when it comes to gender. And this universalist approach, well, in the end, it translated into the methodology that we've chosen to empower women, and at the same time, this approach of cultural relativism that led us to respect the existing social order. So, for example, we had to normalize family units in which you have the leader that has the responsibility to make some decisions. And so here we had to find a balance in between the two, but it was impossible to find the right balance if we because there is no gender parity, even though we worked with our local partners, it was really hard to find that balance. And I think it's important that we keep on reflecting on these matters, because for example, we wanted to recruit a woman to coordinate everything in the field. And the idea here was to make sure that we could represent that active minority. And so here, I just wanted to tell you that we had questions, we got answers. Now we have many more questions, so we basically keep on reflecting on how can we adapt this this approach, this treatment pathways to other social and cultural contexts, so that we can treat children that are severely malnourished. And for some advertisement, there is a short video with actual players that show how a psychosocial stimulation session actually works. And I'd like to thank all of the families that participated, everyone that facilitated the workshop, and all of our different partners, and also you, because I'm pretty sure that you're super tired as well. Thank you. Thank you. It was extremely interesting. Also a great project for you. I mean, it shows that innovating is not about inventing. Innovating can also just benefit, take advantage of what already exists. Let's move on to the Q&A session. We really don't have much time because we're lagging behind. But is there any question in the room yet?
Sandrine, oui? Voilà, OK. D'autres questions? OK.
Bonjour, Sandrine, directrice santé plaidante.
So I am in charge of advocacy work at MDM. Thank you so much for your presentations and those coming. So in all presentations, it was very interesting to see that you were taking into account the specific realities of the people concerned by your research. And I was wondering if you had involved the people concerned. These are questions that we have in mind. It's complicated to find an answer to that. You've talked about it at the end for STEAMNUT. You talked about the people that were involved in the questionnaires, etc.
Je ne sais pas si répondre.
Peut-être une réponse toute petite, mais effectivement.
Indeed. So we have collaborated with Ahmed, and we've collaborated with the coordinator, Isatu, and it was extremely important for us. We've learned a lot of things, especially when we were to build methodological tools. And it's also a question that we had right before on research. What's the link between the researchers and organizations? If we didn't have this link and this co-construction of tools, I think we would have, missed the point. For example, one of the questions in the questionnaire before the implementation, so I don't remember exactly, but the question was to better understand how the children were born. The coordinator told us, you can't say that. You can't formulate questions like this, for example, even for implementation, so we were guided. Another question? Yes, I have two questions for you. First, on the STEAMNUT project. I've understood the balance between, dynamism and culture. Do you think that in your research action we thought, okay, the goal is not to transform everything, or is it something that you'd like to see when replicating this project, being able to put into perspective the different dynamics and to have transformative activities in terms of gender? And the second question, which is more practical, on the cube, the positive pressure. So we have isolated sites. So in terms of electricity, how do you implement that? Thank you. Thank you so much for your question.
Ok, merci beaucoup pour la question.
So, of course, the question around women that cannot make decisions, we know that this is something that has been mentioned in the literature, but we wanted to have psychosocial simulation activities with all of the members of the family that wanted to join. And so we realized that at first, so for the first sessions, we had always a member of the family from the mother's side, and then the mothers also wanted to take that space to be alone. And indeed, we are currently working on the next research project. So we have not taken into account that question of gender, that issue of gender. I think that what really matters is that we have a participatory approach. We're going to involve people, local people, and those people will make sure that the project will last, to make sure that when we leave, the project continues. To give you another example, so we had a lot of questions around family planning activities. Mothers, for example, at least some mothers, wanted to ask questions to social workers to know how to get access to family planning services, even though men and husbands do not agree to that. And it's not something that we had talked about during the trainings with the psychosocial workers, and our answers were the following. Come with your husband, and together we're going to talk and we're going to try and convince your husband. And to me it was extremely interesting. Because by, recruiting local people, we can really transform things. This is not going to be very quick, not as quick as we'd like to be, but we are going to make sure that we can have lasting solutions. And one more question. I'm so sorry, we don't have a lot of time for the CUTS project, so I would like to seize the opportunity of having our colleague here. Yes, thank you so much. When it comes to access to healthcare, so in concrete terms, for negative pressure inside the room, we are using electricity generators, and for all medical devices as well. We're also using oxygen. We have non-invasive ventilation as well. And we have all of the equipment for dialysis as well. So those units need electricity. For now, we were using generators of different sizes depending on the size of the structure. So it can be a constraint, an obstacle. And it's true that now we are part of an environmental approach as well. We are trying to reduce our carbon footprint. So these are reflections that we have in mind, even though the volume can be complicated. But yes, with the cube, we need to work on energy too. And one more question on the CUTS project that has been presented first. If research can show that the low decibel syringes and needles are accepted, feasible and efficient, do you think that this system will be easily available in low-income countries? And what should be expected from pharmaceutical laboratories and companies?
Holy moly. What?
How can this research contribute to making sure they are available? So we know that those systems are expensive. So what would be the consequences as well for our relationships with pharmaceutical laboratories? So for the reasons why we think that those products are not really accessible, the price. So from the very beginning, we wanted to demonstrate the efficiency of those needles and syringes and see if it was cost effective, depending on the context. And we also wanted to run some advocacy work to decrease the prices. With Unitaid, we've really tried to reduce the prices and the cost dynamics. I don't know if that answers the question. I hope so. Well, thank you so much. Thank you so much for participating in that panel. And we know that it's been a long day, so thank you for being here with us till the very end. And I'm going to give the floor to Catherine for the conclusion. So, good evening, everyone. I hope that you really enjoyed that scientific day. The MDM Foundation is extremely important. I think it's the 9th edition, right? It's very close to our hearts. It's very important for us. So 1 minute first to thank everyone. So to thank all of the speakers for today, the teams that contributed to organizing the full program. And I know how important, how difficult it is. They were not very involved in the program, but yet they organized everything. I would like to thank Le Monde as well, because I think it's the second time they've been inviting us. I wasn't there the first time, so I think it's the second time. The participants here and online. And the main piece of information that I wanted to share with you is that we are going to have drinks together in the same place as we had lunch together earlier. So it would be weird for me to summarize everything that's been said, but I wanted to share a few remarks with you. It's spontaneous, all right? How, for example, we can work with and for precarious people. I think that exchange was very interesting because there is a consensus. We need beneficiaries to participate in the process. In all the different works that we carry out, it is fundamental to make sure that we have quality projects being implemented. And it's important to share knowledge. We need to share that experimental know-how. And there is something that emerged from the discussion that is extremely important. And it echoed the previous edition of the Scientific Day, our ability to influence public policies. It was extremely interesting. This is the red thread of today, and it echoed the red thread of last year. So it was extremely interesting. The MDM Foundation, I'm going to talk about it in a few words. So we support local organizations on the issues of sexual and reproductive rights, but we also support research and dissemination of research. How we can share research, how we can disseminate the conclusions of our research, and how we can, embody the results. A lot of people said, okay, we don't listen to researchers. It's very hard to hear that. But yes, we need to see how we can modify our know-how, change the way it's being perceived. So it's part of improving the quality and the impact of our projects, and we have room for improvement. We all have room for improvement, of course, but we need to see how we can improve our know-how and how, by involving participants, we can go beyond, theoretical know-how. And I think that we were able to have different views, different opinions, different ways of looking at history, sociology, epidemiology, psychology. We had a lot of different speakers from different fields of expertise, more than what we did last year, for example. And I think it's extremely important for us to have different views and to better understand the situation. And now I have to conclude. To me, the question is the following. How can we create different types of know-how, and how we can disseminate that know-how, and how we can, embrace that know-how? And the last, image filming a movie on, nutrition, the last project we heard of. We've filmed a movie on contraception and access to abortion. We're not used to working with those methods, and we need to work on that. We need to work with new methods and new methodologies. So I think we need to keep working. I think that we can, at least a little, influence public policies. Otherwise, maybe what we do is useless. And let's have some drinks together now.